Nothing but the finest. So you guys start research eval tomorrow, correct? Yeah? Research eval and the Capstone project kind of go hand in hand. You really can't do the Capstone project without having some knowledge of how to look at the medical literature. Through this course and research eval, we want to give you guys an introduction to the medical literature and how to evaluate the literature. Not all literature is created equal. A few years ago when I taught research eval, I used an article. Did I tell you guys about this during? No, okay. I used an article that I found in a South American journal, and it was written during COVID, and it was a study on ivermectin. Okay, hot topic. I was intrigued, and then I started reading it. They had a really, really small group of participants in this study, maybe about 40, and about halfway through, they mixed up control and drug, and they kept going. It was literally the worst article I've ever read that was published in anything. It was terrible. I actually used it as one of the articles for the article critique, which you'll be doing in research eval, in the hopes that students would pick up on what a horrible article it was. They did, and I was very, very happy. I have added you guys to the master's seminar homepage so you guys can actually reach your course material. I did that last night and discovered that none of the links to the PowerPoints worked. I fixed that. And if you go to the home page, this is what you're going to see. And I haven't created the assignments yet, so don't look for them. But when you go to assignments, this is what you should see. And you'll also see, like when you open up your dashboard, on the right-hand side, there's going to be things to do, and that's going to be upcoming assignments. Tests, writing assignments. For research eval, it'll be your article critiques. Freshman semester, you're going to write a PICO statement. PICO stands for Patient Intervention, Comparison, and Outcome. And this is going to help you frame your clinical inquiry rough draft, final draft, and then presentation. Oops, those deadlines are incorrect. I will fix. This semester, all you do is the PICO. It's literally one page, and it should just take a couple hours. Next semester, you're going to turn in the rough draft of your clinical inquiry. A clinical inquiry is simply forming a medical question and turning to the literature and looking for an answer to support it. You might have a patient that comes into your office that's 4 months pregnant and has a history of hypertension. Let's say her hypertension is mild, and your question is, well, gee, should I be medicating that? You're going to turn to the literature to look for that answer. Are there any controls for those blinds? Where? Okay. So I see a few of you going, ah. Junior semester, you're going to complete your final draft. And then senior semester, this is fun. You're going to present your research to a panel of 3 staff members. This year, I'm trying to get some participation from around Medco. So hopefully by the time you guys are seniors, we'll have some representation from throughout all the programs here for our clinical inquiry presentations. A number of our students have gone on to take their clinical inquiry presentation and actually present at conferences. And we have a couple students that are trying to get them published. Years ago, we used to do a super long paper. You might have heard about that. You know, oh, you're going to go to IPAP, you're going to write a 20-page paper. Yeah, we don't do that anymore. Then we shortened it to a 5 to 10-page paper. Nah, we don't do that anymore. It's just this clinical inquiry, which is literally an introduction to the medical literature. In your schedule, you see a bunch of yellow, and it's marked Capstone Research. That's a little bit of a numbers game with TRADOC. We have to fill the schedule. There can't be any blank spaces. Your time is supposed to be accounted for from 8 until 5. And the way that we do the extra accounting is we say you're doing research. So if anyone ever asks you what that yellow is for, it's for research. There you go. Grading scheme is the same for this project as for everything else in IPAP, 75 or above. What happens if you don't turn in a portion of the capstone? You'll go to a PRB, and we have held people back because they failed a portion of the paper. Yeah. I don't know. I don't know why. There was one, his rough draft was trash. I mean, it was terrible. I told him exactly what to fix and how to do it, and he didn't. And then he was shocked when I failed him when he was a senior. Whatevs. There's 2 parts to the master's capstone grades. You get 1 credit in phase 1 and 2 credits in phase 2. In phase 1, your grade is going to come from the rough draft, and then your final draft, and then your clinical inquiry presentation. Phase 2, there's a whole bunch. You're going to do an actual case report, case study, whatever you want to call it, same. Inevitably, in phase 2, you're going to find a really cool patient presentation. Hopefully it's something super rare, but not deadly. And you're going to write that case up. And then you're going to present it to your phase 2 coordinator and possibly a few other people, maybe your peers, whatever they want to do for the panel. You're going to do an OSCE. Do we know what an OSCE is yet? No. Okay. You're going to find out. You're going to start with Clin Skills 1, correct? Have we already started that? Then Clin Skills 2, sophomore semester. Junior semester, you start Clin Core. And in clinical correlations, we'll give you an actual scenario. Like 50-year-old male presents complaining of hypertension diagnosed at a health fair. And then they'll have a list of things that they'll say if you ask, physical findings, and then you have to come up with a diagnosis, a differential diagnosis, and a treatment plan. And for the OSCE, instead of just practicing that, you're going to get some random case, and you're going to have to go through it just like you do in ClinCore. That's what an OSCE is. The objective standardized clinical exam. Some places do this in stations, like you have a history station, you have a physical exam station, then you have an assessment station and a plan station. There's too many of you for us to do it that way. So you get one big glob of the case, and it'll be graded by one staff member. In phase 2, you're also going to do a presentation on a disease of current military importance. Micro is usually a good place to look for those topics. And then you get to do a presentation of something that's interesting to you. As you go through and you start developing your PICOs, some of you are going to come up with some complicated PICOs, and I'm going to tell you that's too much. You can do that for your personal interest presentation. The PICO for your freshman semester should be simple and clear-cut. Don't make it too elaborate because you're going to create a lot of extra work for yourselves, and I don't want that for you. The final part of your grade in phase 2 is a thing we call personal attributes. Be where you're supposed to be, do what you're supposed to do, and don't lie. And don't call a nurse a B word, and you'll do fine on the personal attributes. Actually happened. You know what? It was the same guy that I failed for the paper. Called a nurse a B word. That was a PRB. We almost relieved him. I won't tell you how I voted, but yes?
On the previous slide for phase 2, so the first 3 bullets are the same topic?
No. No. So your case report and your case presentation, that's going to be your interesting patient from phase 2. And then these two, the disease of military importance and medical topic of personal interest, those you pick. Yeah, it's 3 presentations in phase 2. Plagiarism. We are in the early stages of drafting an AI statement. If you choose to have AI create your entire PICO, AI is not perfect, and we're going to look at it and go, wait, what? AI is a tool. That's all it is. It's a tool. It's not perfect yet. So do the right thing. Come up with an original idea. If you need help with formatting, AI can help. If you need help with your reference list, AI can help. But you always have to check AI. Plagiarism, we did have one student that had to do a extensive rewrite of one of their projects because they chose to basically cut and paste out of some articles. It's stupid. Don't do it. We do use anti-plagiarism software that will check your final submission, and it is far more critical than some of the free software that you can find. Is it available to you? No. It's the nature of how it's set up. All right. Any questions on what the overall project is going to look like? Okay. How are we liking IPAP so far?
It's the best thing ever, man.
Lies. Let's see.
Scott's really killing it.
Okay. Is your first test this Friday? Or is it second test? Third. Ooh. Wow. There we go. Okay. I will get new deadlines for you. These are due, all your projects except for the CI presentation are due at the end of the semester. Okay? So you have some time. So I'm sure most of you, especially those of you that are new to medicine, have no idea where to pick your topic. Your counselor can help. And after I finish the lectures, there'll be some additional class time where I'll come back just to help you. I'll sit here and you can pick my brain and I can help you fine-tune your PICO into something workable. Yep, what?
Give us an example of like what one would be, you know, like what some of the topics would be.
Yes and no.
Okay.
So we used to have, when we did the 20-page paper, I had a 3-page list of viable topics. The CI, the clinical inquiry, is a lot more vague because it could be anything. So like are antihypertensives indicated in pregnancy? That's an example. Does testosterone replacement therapy cause increased cardiovascular risk? That's another one. Does hormone replacement therapy in women contribute to cardiovascular disease? The answer is no. And that was a big deal this year. For 20 years, the FDA had a black box warning on hormone replacement therapy for women. And it was based on a flawed study. They have recently removed that. And it is one of the biggest deals in healthcare that you don't hear about. Same thing with testosterone replacement in men. Years ago, there was a couple studies that said that testosterone replacement caused heart attacks. No, it doesn't. Now, are there reasons why young, healthy bodybuilders keel over dead? Yes. Is it related to testosterone replacement therapy in men who are testosterone deficient? No. Anyways, so those are the kind of things that you can look at. This is what the whole assignment actually looks like. Your freshman assignment, 1 page. Literally could do this, I could do this in an hour, and I have an example of one for you that I did in an hour. It'll probably take you about 3. It shouldn't take more than that. Here is the rubric which you will find under the assignment submission. Okay, the PICO. P, patient problem or population. You could be looking at a group of people, postmenopausal women, a specific patient, or a problem. Those are, the problem ones are kind of cool. And some of you will accidentally discover that your PICO is a problem, not a patient. The intervention is what are you looking at? So in the hypertension and pregnant patient, you're looking at antihypertensives as the intervention. Your comparison. Sometimes there is no comparison. Sometimes there is. If you're looking at, say, is platelet-rich plasma better for controlling knee pain than steroid injections? Now you've got a comparison. Not all of your PICOs are going to have a solid comparison. Sometimes the comparison is no treatment at all, especially if it's something new, like an entirely new drug class. And let's say it's the first treatment for a problem that had no treatment before. In the past couple years, for the first time ever, we've been developing effective treatments for ALS, amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. Years ago, we had nothing. If you got diagnosed with that, you were going to die, and it was going to be quick. I had a patient with ALS. I was working in pain management, and she was in her late 40s. She was a psychologist, and she was one of the meanest people I have ever met in my entire life. I mean, this woman was a straight up B at our first visit. I mean, she was just awful. And her presenting symptom was right arm pain. Now, for most of us, that usually comes, if you're having pain radiating from your neck into your arm, most of the time it's coming from the neck. And given that she was in her late 40s, she had some degenerative changes on her MRI. We tried a couple of different types of injections. Nothing helped, and she continued to get worse. That was month 1. By month 3, she came in a wheelchair, and she'd gotten the diagnosis of ALS. By month 5, she was in a wheelchair that she controlled with one finger because that was all she could move. The last time I saw her, which was about a month after that, she came in and profusely apologized for being such a total B for the rest of the time that we took care of her, and then she died. That was fast. Yeah. Welcome to your new world. Sometimes you're going to have patients that die. The final O in the PICO is outcomes. So in the pregnant patient with the hypertension, what's our goal? Control the hypertension without causing harm. All right, so for the P, you can look at a number of things. You can look at a specific age group. So maybe you're looking at something regarding children. So you're going to need to select a specific age group. Hot topic right now, vaccine and autism. There was a time where I would have told you there is zero evidence to link vaccines to autism. And I bumped into a friend recently. He had a little boy think he was about 5, and they were playing golf together every weekend. He was training him to be the next Tiger Woods. At age 7, he became autistic. Around age 7, we give a crap ton of vaccinations to children. Is it possible? Maybe. Can I 100% for sure say there is no link? No. Can I say 100% for sure that there is a link? No. It's my kid. I want to be sure. Granted, with a lot of the childhood vaccines, we have prevented many, many deaths. Can we do it better? Probably. And that's a challenge to you guys for your careers for the next 30 years. Do it better. All right. More intervention. So what are you looking at? It could be a procedure like vasectomy. Does vasectomy cause, I don't know, decreased testosterone in men? That could be a thing. You could turn to the literature and look for the answer. Fun story. Nobody dies in this one. Phase 2, I'm doing a urology rotation, and it's vasectomy day. I mean, literally, urologist has a bunch of vasectomies lined up. And he says, hey, PA student, have you ever done a vasectomy? I'm like, clearly no. And he said, well, you're going to. I was like, oh, cool, okay. We walk into the room, guy's sitting on the table, urologist goes, his name was Tim Taylor. Tim the tool man. Yes, for real, for real. Dr. Taylor goes, this is PA student. We are going to do your vasectomy. I'm going to do the right side. She's going to do the left side. And the guy sits up and goes, no. And he goes, that's your right. However, if you refuse, I'm going to send you downtown and you can pay a copay. Times were a lot different back then. So needless to say, I got to do the vasectomy. Not as easy as you think. The vas deferens is very, very slippery. Like, yeah, oh yeah. Very, very slippery. Like a slippery piece of linguine that you're trying to grab with chopsticks. Okay? So Doc does his side. It's not complicated. I go to do my side, grab the linguine. Linguine pops out of the tweezers. Grab the linguine, pops out of the tweezers. Finally, get it, tie, cut, snip, snip, tidy everything back up. Guy stands up. Side that Doc did looks normal. Side that I did, there was already a lot of swelling. And a few minutes later, I see the guy walking down the hallway. Like, okay, I got better. Thank God. All right, in the vasectomy example, your comparison would be no vasectomy. Outcomes. All right, so could be reduced testosterone, testicular cancer, whatever. Here's what the whole thing would look like in men. That's a specific population. Does having a vasectomy increase the risk of testicular cancer in the future? So what's your comparison? No vasectomy. What's your outcome? Testicular cancer. Wow, that is kind of hard to see. So there's some examples. It's on the page. I'm not going to read them to you because I would hope that everyone that's here can read. Although I know some people like to read slides to you. Sorry. You're going to learn about the different types of literature and what a lot of the words in the medical literature mean. Quantitative and qualitative. Big difference. Objective, subjective. Big difference. When you start going through research eval, one of the central tenets of research evaluation is the quality of the literature. All right, so at the very tippity top of all the literature, you have meta-analyses of systematic reviews. Those are going to have the best data. And at the very bottom, you're going to have opinion. Okay, that's the worst. That's how we got the opioid crisis. Did I talk to you guys about that before? Okay, sometimes I bring it up at the intro. The opioid crisis started because of an opinion. And it was an opinion piece published in the New England Journal of Medicine. And it was some doctors at a hospital in Massachusetts that said, we should treat pain vigorously. That we as a society under-treat pain. And if we do it with prescription medications, it's safe and hardly anyone gets addicted. That was the start. There were a couple of pharmaceutical companies that latched onto that and said, look, here's an article that says prescription opiates are safe. And then these people went on to create extended release OxyContin, fentanyl patches, extended release morphine. When you take an old drug that's already been approved through the FDA and you modify it somehow, it becomes a new drug. So by taking morphine and making it extended release, now you have a new drug that costs you virtually nothing to get FDA approval for because the base drug was already approved. So these drugs made a crap ton of money for the pharmaceutical companies. And they heavily marketed how safe they were and that people wouldn't get addicted. Well, guess what? They got addicted. And then we had this whole shift in culture where pain is the fifth vital sign. And gosh, if you come in with 10 over 10 pain, we have to medicate you until you say, I feel better. Now, you go in an ER and your arm's hanging off and you're going, it hurts. You know, they go, here's a Tylenol, right? So pendulum's probably going to need to shift back more towards the middle. But there was a reason for why the opioid epidemic happened. In the United States, we consume 90% of the world's opioids and 70% of the world's prescription drugs. Yet our overall mortality and morbidity is in about the middle third of the world. Are we doing something right? No. No. Okay, so at the tip of the top, we've got those meta-analyses, and what those are, let's say we do a randomized clinical control trial looking at the effectiveness of a new GLP-3 medication called retatrutide. Okay? We do a randomized cohort, randomized clinical trial, and we've got 2,000 participants. Okay, that's one. Let's say there's 6 different trials across the country with 2,000 people. A systematic review will take all of those clinical trials and compile the data. That makes it statistically stronger. Then, once you've got 10 systematic reviews looking at 10 randomized clinical control trials, then you take all those 10 systematic reviews and you do a meta-analysis where you look at all that pooled data. It makes it very, very strong. Not always without flaws, but the data is much stronger. So that's why it's at the tippity top. And when you start looking at your research for your PICO, the more meta-analyses and systematic reviews that you can find, the stronger the evidence. Oh yeah, this is a question I actually had to write a paper about. In patients undergoing lumbar spine surgery, is the minimally invasive approach better than the open approach? Intuitively, I thought, yeah, minimal, got to be better. Long-term outcomes are pretty much the same. And that's what I found in the literature, and I was very disappointed. However, short-term outcomes for minimally invasive surgery were better. Less infection, people got around faster. I was still kind of disappointed though, because I was so sure. But it's not what the literature supported.
When you say the literature, are you referring to studies that already exist?
Yes, absolutely. In high-quality peer-reviewed journals. Not that South American journal that I dug up that ivermectin thing in. That was hands down just god-awful, and I don't know how it got published. Other than, hey, maybe somebody's going to use this as an example of really bad literature. Because that's what I did. When I start doing research, for my keywords, my search words, you had a chat by the librarian, right? Okay. Librarian talk about searches and keywords. Okay. I look for exactly what I want. Because sometimes I hit gold and I get what I want by asking, like for the minimally invasive spine surgery, I literally said minimal invasive spine surgery versus open. And it gave me a bunch of good literature. Sometimes you need to play with the words to get what you want. Date range. For your PICO, it's very short, lasts 5 years. For the clinical inquiry, it expands to 8 years. So it's a broader window. Why did we do that? Because we want to keep the PICO short. I guess it's break time, yeah? Take 10, and then we'll pick up right here. What's up?
I don't want to be put in the cart before the
Class leader. Oh, there she is. Hey. Oh, it's Ruggiero? Yeah, he's amenable to movement. All right. Yeah, he used to be an IPAP instructor. I don't know if he told you guys that. And then he was here as a military member. Yeah, he's been around forever. All right. Okay, so where are you going to find your research? I recommend, and you can use whatever you want, I recommend PubMed because it's free. There are some other databases that are better, but they're not free. If you find an article that you want, but it's not free, go to the library and ask them to get it for you. Or check Magoogan. You have access to both. Sometimes Magoogan will even order articles for you. Let's see. Oh, all right. Things to narrow your search with. That lasts 5 years for the PICO, and then 7 or 8 years for the clinical inquiry. One of the filters that I like clicking is abstract. I want good peer-reviewed literature that has an abstract. And an abstract is a snapshot of what the article is. It's designed to get you interested in clicking on that article. Because when you click on an article, the author gets a little count. And if you're in research, that's important. Even better, if you cite someone else's research and your research gets published, then they get a cookie. That's how research works. For you guys, and for what this project is, you could also select free full text as a click in PubMed. If you're doing higher level research, that is frowned upon. Only searching for free full text articles. I found that out when I was doing my doctorate. It's a good thought, Denise, but no. No. You gotta get rid of that free full text. How many people speak another language? Okay, a couple. Found a really great article once that was in Russian. Yeah, I couldn't use it. If you speak Russian, okay, great. But otherwise, you could just click English only, and that'll limit that. Human studies versus animal studies. As we were having a discussion a few minutes ago, animal studies don't always replicate human studies. So some of you might have like this cutting edge topic, and the only literature that's available is animal studies. It is what it is, but it's not very strong. There's a difference between literary databases and point-of-care resources. A point-of-care resource is something I'm going to use in the clinic. So that pregnant patient that I want to give an antihypertensive to, I could jump into a resource called UpToDate, and UpToDate has already combed the literature and gotten some answers. And I look at that and go, oh, all right, this one's safe, and I'll prescribe that. Point-of-care resources are not literary databases. If we see UpToDate in your reference list, that's a huge no, hard no. Oh, and through your Stimson Library membership, you can actually get UpToDate for free. But you'll have to like use a military account.
I know there are the peer-reviewed journals. Aren't there articles that are published but are not published through those journals? And are we able to, is that a source as well?
Frowned upon, because peer-reviewed literature means a group of learned individuals looked at that article and picked it apart for validity, for method. Was it done properly with scientific method? And if the answer is no, like if it's a newspaper article, I would stay away from those.
Yeah, I guess I'm not talking about newspaper article. I'm talking about medical published study, but not through the Journal of American Medicine. And some of them don't make it into the
An
journal.
unpublished study, I would try to avoid using something like that. Stick with those peer-reviewed journals. Because if it didn't get published, there's a reason. And it probably has to do with method. Yes. Oh, what's up?
I remember when I was going through the public health program that not all peer review is the same. That
True.
Sometimes, like, you can buy peer review.
Yes.
And everything.
Yeah, that's true. That's true.
So my question is, how do you separate out what's garbage and what's actually good?
Okay. A South American journal that I've never heard of, and New England Journal of Medicine. Not picking on South American journals. There are some very respectable ones. However, that journal I'd never heard of. It was shady. And you can actually look at what a journal's criteria for publication is. And if the first thing it says is $1,000, yeah, here's your sign. That might not be a great one. If you go to the library tab, so if you have any of your courses open, on that left-hand side, there's going to be this big menu, and it's going to say library. If you click on that, that will take you to Magoogan. That is UNMC's library. And when you click on it, this is what you're going to see. And at that top left, literature databases. Or you can just Google PubMed, pull it up, create an account. And I suggest creating an account because if you have an account and you're logged in, you can save stuff, which will work until they update their database and then it dumps everything. So be redundant if that happened. When you click the literature databases, this is what you see. And again, difference between point-of-care resources and databases. What are we not going to cite in our reference list? Yeah, no up-to-date, no Medscape, no nada. Back to keywords. I always, like I said, I always start with exactly what I'm looking for. And the first place I go in, I just drop it into Google. Literally. Drop what I'm looking for into Google. And if that pops up with 1 million results, I know literature exists. Okay, check. Then I go into PubMed, drop in what I want. And if it gives me anywhere between 100 to 500 results, I'm happy. If it gives me 10,000, then I know I need to start narrowing my keywords. If it gives me 10, but they're good, I jump for joy because I don't have to look through a whole bunch of articles. If it gives you 5 and they're really good, yeah, your work is done. But if it only gives you 2 and they're okay, then you need to tweak those keywords. This is what the front page of PubMed looks like. And you can log in with a Gmail. For a search, again, I drop in exactly what I'm looking for. And then I start adding filters. The filters are off on the right. And the first thing I do is I adjust the date. I already told you 5 years for the PICO. And that's what you get with some of the searches. Now at the top, that's a suggested. PubMed suggested it, but for some reason it didn't come up in the search. Look at it. Usually they're pretty good. Another method you can do, let's say you have a really niche topic and you don't get very many articles. You can open up, I usually pick the best one, what looks like it's the best one. You can open it up and drop down to the reference list of that article. That's called snowballing, because then you can cherry pick out of that reference list. In PubMed, you can save your results and you can even email them to yourself. I recommend that you do that because every 2 or 3 years, they completely reset their database and you lose everything. I can't even see what that says. I'm old. Ah, yeah, email. Email it to yourself. Save it. And save the whole results, not just the one page. You have to drop down to ask for that. Filters. If you get 10,000 results, you're going to want to start dropping in some filters. That date range, adults or children, whatever you're looking for. English. You can ask for just meta-analyses or systematic reviews. Did the librarian talk about any of this? Okay, good. Just want to know how fast I can go. All right. As you add filters, you narrow the amount of results. You can also go into advanced and set some more filters there, but you probably won't need to do that. If you're crafting your PICO and you start using a lot of words like and or, you're probably going too much. And I'll tell you this, and you guys, somebody's going to do it. They're going to bring me a PICO, and it's going to be a very long PICO, and there's going to be that little conjunction, and I'm going to tell you, drop off everything after and. All right, so we're saving. How do I pick a topic? If you are completely lost, you need to start reading about medicine, reading about changes in how we do things. Medicine's changed a lot since I went to PA school. In PA school, I was taught that only women get multiple sclerosis and only men get Lou Gehrig's disease. And we know that that's not true now, but that was what we knew then. How did I learn that this changed? I read about it. I read about the changes. Some sites that you can look at: Medscape, Up to Date, Medical News Today. Some of these are a little biased, but they have good information. You just have to sift through it. All right. How are you going to do your PICO? Don't wait until the last darn minute, because a lot of you are going to look at the schedule and go, oh, there's a lot of yellow space towards the end of the semester. I'm just going to Yeah, don't. Start thinking about it now. There's going to be a couple of 4 days throughout the semester. I suggest utilizing those to knock this out, because you could literally finish this whole thing in a day. And once you get the draft finished, it's much easier to refine than it is to create. Anybody ever use Grammarly? UNMC used to have the full Grammarly suite. They do not anymore. It's very sad. The free one is okay. UNMC does have a writing lab librarian that you can access through UNMC. I don't anticipate you needing that for the PICO. You can ask your counselor. You can ask me. If you can't find me because I'm in meetings like all frickin' day long, email me on Canvas. I might not answer you right away, but I will answer you. Again, this shows you how to find McGugan. Everything that we do here is an AMA, not APA. Why? Because AMA stands for American Medical Association versus American Psychological Association or Psychiatric Association. Big difference. AMA is a lot cleaner in how we do references. So when you do your in-text references in APA, you say, according to Stahl et al. In 1980, that's APA. In AMA, you say, a cohort study, and then there's a superscript, looked at testosterone replacement therapy versus that whole Stahl et al. 1980. Yeah, no. Most of the articles that you're going to read are going to have those superscript numerals or some variation thereof. Also for our journal, AAPA, American Association of Physician Associates, we use AMA. Most of the big medical journals all use AMA. So we're going to get away from that APA undergrad stuff. I give you a template. Use the template. Don't go off the reservation. Stick to the template. That's why it's there. Part of this exercise is following instructions. Can you follow instructions? Yeah, that's how you got here. You follow the instructions to make your packet. Don't go rogue now. Cover page. We already talked about this. This is the full-on definition of plagiarism, taking credit for something that's not yours. Putting a large passage from an article in quotation marks is wrong. That's just lazy. If I see that, I will call you out and go, hard no, That means I'm too lazy to reword this in my own words. Hard no. Oh, also, somebody in here is going to be a hyphen king or queen. I promise you. Hyphens should only appear inside of words like 22, 20-2. We don't use them for emphasis in medical writing. You do that in creative writing and discussive journalism, but not in medical writing. Somebody will do it. Somebody in every class does it. All right. Let's see what else we've got.